Right, welcome, welcome everybody. What I'll do is I'll just go through some of the formalities to start us off. So obviously this is a meeting of the Tees Valley CCG Primary Care Commissioning Committee. So if you think you're meant to be at something else, log off log off now. It's a business meeting of the CCG and it is held in public, so that members of the public that are able to join us today can observe the operation of the Primary Care Committee. Because of the current restrictions, we are holding the meeting on Zoom. We would normally be in at North Ormsby, but we've had to hold these meetings on Zoom for a while now. The meeting will be video recorded and will be available publicly, so please be aware of that. To allow smooth running, please can I ask people to put the mobile phones onto silent, use the Tees Valley background if you can, says she who isn't. I've not quite mastered that on Zoom. I've mastered it on Teams, but not Zoom yet. In order to minimise background noise, please can you put yourself on mute unless you're willing to speak, and if you can use the raised hand icon. But I've got most people on my screen, so please just wave at me, or I'm sure somebody will let me know somebody wants to ask a question if that's the case. If you need to leave your seat to get any parcels or anything, please turn the camera off when you do so, and then put it back on when you return. If I do have any technical issues, which I'm not expecting, Michelle will take over chairing from me. And so we've got the following members of the public have been said that they're going to come along. So we've got Mr. Patrick Moyo. I don't know, is Patrick there? No, I don't think Patrick's joined us yet. Well, if he does join us, he's a healthcare partnership manager. We've got Miss Anna McLaren. Are you there, Anne?
Hi, I'm here, thanks.
Hi, Anne. Would you like to introduce yourself, Anne? Where are you from?
I've just joined out of interest because I'm interested in different careers. So I thought it'd be good to see the business of the committee.
Oh, lovely. Well, welcome. Please feel free to, there's an opportunity to ask questions at the end. So if you want to ask anything or have got any observations, we'll probably pick those up at the end if that's okay. Yeah, lovely. And then the other member of the public was, would you like to introduce yourself? CB.
Hi, I'm Chris Bindane. I'm a local democracy reporter based in Sunderland, but I'm here today for the Hartlepool Mail.
All right, lovely. Welcome, Chris. I think we normally have, is it Nick Marco comes along to the meetings, so Nick normally comes along and attends, but very welcome to see you here.
Thank you.
Okay, thank you. Right. So let's have a look. So what we'll do is we'll go around, I'll go around the people that I've got on the screen, and everybody will introduce themselves for the benefit of the members of the public that we've got. So I'm Caroline Gitcham and I'm a lay member and I'm the chair of the Primary Care Committee. So if we can go next on the screen, I've got Corp Gov. Would you like to introduce yourself?
Oh, sorry, Caroline, it's Jane Smales. I'm here just supporting Caroline Harvey in her first committee meeting today.
Lovely. Caroline, do you want to give us a wave so people know who you are? Yeah, lovely. Nice to see you, Caroline. We've got Sue Greaves.
Yeah, I'm Sue Greaves. I'm head of commissioning and strategy for primary care at the CCG.
Lovely. David Emerton.
Hello, I'm David Emerson, a secondary care doctor on the governing body, which is a non-executive role.
Lovely, thanks, David. David Gallagher.
Yeah, thanks, Karen. Afternoon, everybody. I'm Dave Gallagher. I'm the Chief Officer of the CCG.
Lovely. Janet Walker.
Hi, I'm Dr. Janet Walker. I'm Medical Director of the CCG. And Caroline, I must apologise. I have an urgent COVID call at 3 o'clock, so I'll have to sneak off for that. Sorry.
Okay, that's smashing, Janet. Thanks. Then we've got Janice.
Hi, I'm Janice Foster. I'm Chief Exec of Cleveland Local Medical Committee, and we support and represent general practice in Tees.
Lovely. Karen Hawkins.
Good afternoon, I'm Karen Hawkins. I'm the Director of Commissioning for Primary and Community Care in the CCG.
Lovely. Kevin Nicholson.
Good afternoon, I'm Councillor Kevin Nicholson, and I'm a member based on information from Dartford Borough Council that I have to come along and join the good old team that is the Tees Valley Board. So, hello everyone.
Lovely, hello, hello, very welcome. Right, me things jumping about as this always happens. I've got Culvey.
Good afternoon, I'm Culvey Fedrich. I'm a Primary Care Manager for NHS England.
Lovely, nice to see you, Culvey. And then I've got, let's have a look, I've got Lisa Jones.
Hi, good afternoon everyone. I'm Lisa Jones. I'm the Public Health Strategic Manager for Healthcare and Health Protection.
Lovely, welcome. And then I've got Lynn Walton.
Hi, yeah, I'm Lynn Walton. I'm a Deputy Chief Finance Officer for the CCG and I'm standing in for the Chief Finance Officer, Mark Pickering, today.
Lovely. Michelle Thompson.
Hi everyone, I'm Michelle Thompson and I'm the lay member for the CCG for Patient and Public Involvement.
And then we've got Sue. We haven't done you, Sue, have we? Sue Greaves?
Yes, you have.
Yeah, I thought we had. Sorry, Sue, I'm working my way down the list. And then I've got Susan Jane Hall.
Hello, Susan Jane's my Sunday name, so it's Jane Hall. I'm Head of Quality at Tees Valley CCG, just newly appointed.
Oh, lovely. Well, very welcome, Jane. Nice to have you. Have I missed anybody? No. Smashing. Sorry about that. Like I said, everybody starts jumping about on the screen. Right. Well, now that we've done that, we'll make a start. So we've got some apologies. So I'll go through the apologies. We've got Mark Pickering, Peter Smith, Hannah Heron, Robert Upshall, Ali Tamasibi and Christopher Akers Belcher. Is there any more apologies? No, lovely. Okay, well, we are quorate. I'm just checking if Janet leaves the meeting at 3, will we still be quorate?
Yeah, David Emerson is makes that quorate. Yeah, that's fine.
Yeah, brilliant. Okay, that's smashing. So we can continue in comfort then. That's great. So in terms of notification of any other items of business, I haven't been notified of any. Has anybody got any that they would like to raise? David, yep.
I was wondering, with the ongoing publicity about face-to-face appointments in general practice, whether we should give some assurance that they are available, but other means of appointments are also being used, which does increase capacity. Just as it's a public meeting, as I thought it might be an opportunity as there's so much publicity.
That's smashing. I'm happy to take that one now if people are happy to do that. Karen, are you able to respond to that?
I can, Caroline. It might be best to do that under any other business, and I'll provide the committee with an update of recent guidance that's been released around improving access in primary care by way of an update and in advance of the next committee, and it'll cover off both things at once. But rather than detract from the business of the day, if we take the business of the day first and then cover that under any other business, I think that would be helpful.
Okay, yeah, I'm happy to do that if that works. Yeah, okay, lovely. Right, so then declarations of interest. Obviously, everybody's got the obligation to declare any interests that they might have. There's a table that's attached to the minutes of the meeting where everybody has all of their interests already declared. But if there's anything specific, I'm aware that on item 46, the prospect surgery for the CQC inspection, Sue Greaves was previously employed there as a practice manager between 2012 and 2015. So to ensure that any potential conflict of interests were managed, Sue hasn't been involved with any of the discussions or subsequent support to the practice by the CCG with regards to the inspection. Although in attendance at this committee, she's not a voting member and as such can still receive the paper and be included in any discussions. So presume everybody's okay with that. Janice, do you want to comment on that?
It wasn't on that specifically, it was just around the declarations of interest by way of, obviously, as Cleveland LMC, we have been supporting some of the practices in some of the papers that have come to the table today. And it was to reassure that any comments that we've made, I think they form part of the bundle when it comes to the premises, etc. And on the CQC elements, we actually have separate people within the LMC dealing and supporting these practices there. But there's certainly nothing that we wouldn't be saying publicly anyway.
That's smashing. Thanks very much for that. Thank you. And then on item 48, in terms of the primary care budgets, obviously GPs on the primary care committee will have an interest in the related contract and budget values for primary care, but these are based on national agreements. So no further action is required to manage those particular interests, and the information summarised in the paper is based on national contractual agreements which have already been confirmed, and there's no decisions required. And like I said, I've had no further declarations of interest. So if we're okay to proceed with that. Janet, did I see your hand up?
It was only to note, Caroline, that I'm a non-voting member of the committee anyway, because obviously with the unsolvable conflict from a GP perspective. I have left my practice. I'm not currently working in my practice at the moment. However, obviously that it needs to remain on the register for some months after I've left.
Okay, that's smashing, Janet. Thanks for sharing that. Right. Well, if we can get into the content of the papers, then on page 42, we've got the minutes of the previous meeting, which was held back in August. That is months ago. I was thinking it seems like months ago, but it is months ago. So if we can confirm that the minutes of that meeting are an accurate record, or if there's any amendments that people would like to make, can people confirm that they are an accurate record? Yeah, few nods there. Okay, yeah, I'm going to say that they are. And then in terms of matters arising and the action log, I don't think that there was any actual matters arising on that action log, was there? Let's have a look. No, there wasn't. Has anybody else got any other matters arising from the minutes that they would like to raise? No? Lovely. Well, then we'll go straight into item 2.10. So, sorry, it's not item 2.10, it's item 14. And Sue is going to take us through the Zetland medical practice, which is the application for branch closure. So over to you, Sue.
Thanks, Caroline. Okay, so Zetland Medical Practice has submitted an application to permanently close its branch surgery in Saltburn. The branch was temporarily closed in March 2020 because the practice were unable to maintain a COVID-safe environment in line with national guidelines. And it also, as it allowed the practice to consolidate all the staff on one site, the main site in Mask. It therefore increased resilience of the practice during the COVID pandemic. The purpose of this paper is to provide Primary Care Committee with additional information to help you consider the application and the recommendations contained. So in terms of the temporary closure, this was approved until the COVID-safe environment requirements were amended. The National Guidance was amended on the 14th of October, reducing the social distancing measures from 2 meters to 1 meter, but required the continued use of face masks. But also the configuration of premises, local capacity and ability to ventilate should also be factored in making any decisions around the temporary closure. In terms of the permanent closure, in January 21, the practice contacted the CCG for advice on the process around a permanent branch closure application. And they cited a couple of reasons, really. One was around the premises, which they felt were not fit for purpose. They have 2 clinical rooms there. There's no scope for the premises to be developed, lack of natural light, single glazed windows, no central heating, visible signs of damp. The practice reported that they have explored alternative options, but the cost of these, and together with the long lease lengths, have been too prohibitive for them. The other reason that they cited was around workforce, and they have had staff have left and they've been unable to recruit. Oh, I've got a message there. Oh, is that just Lisa that can't hear me? Can everyone else hear okay? All right, okay, I'll carry on then. They did say that they felt that the benefits of consolidating on one site would be to enhance clinical quality. It would support practice resilience and provide sustainable high quality care for the patients. In a modern infrastructure, it would support recruitment and improve staff morale. In terms of the premises, they are leased from a private landlord who we understand from the practice is not willing to update the premises further. The size of the premises, we use something called the premises maxima guidance, which is a guidance in terms of the size of a practice, the space required for the practice list size, and that indicates that it is slightly, that if the branch surgery closed and everything consolidated onto the mask site, it would potentially be slightly small. However, the practice confirms that they are confident that they will be able to provide services for full complement of patients from that building, and considering also that the branch surgery has been closed since March last year, so effectively all patients have been utilising the mask site. There are new technologies available that will support remote consultations as well, where that is appropriate. In terms of the workforce, the practice have confirmed that they will not be making any redundancies as a result of the branch closure. In terms of access, it's 2.5 miles between the branch site and the main site. It is accessible by car, bus and train. All patients have been able to access both sites when they were open, although approximately 624 of the 7,200 patients have been more likely to access. Oh,
so it's okay.
So, okay, sorry, I keep seeing messages pop up. Have been, sorry, 624 of the 7,200 patients have been more likely to access the branch surgery. As the practice boundary won't be changing, the practice will still undertake home visits to all patients regardless of where they live. There are four other practices within a 5-mile radius of the branch, all of which have open lists, and there are some housing developments either developed or planned over the next 4 years, approximately 75 new houses, although it's difficult at this stage to estimate what the impact of that might be, because we don't know whether those patients live in, people who would move into those houses are already patients of practices and may not want to move anywhere. In terms of the financial impact, the reimbursable costs, so they're the costs that the CCG reimburse to the practice in terms of rent, rates and water, are in the region of £12,500 a year. And in the event that the branch, that it was approved that the branch closed, then those costs would not be made to the practice, so that would be a saving to the CCG, so that's approximately 12,500. However, the practice would be responsible for any dilapidation costs when they were exiting the existing lease. So the CC, if there were any dilapidation costs, that would not be a responsibility of the CCG. In terms of practice performance, the latest GP survey, which was undertaken in July this year, did demonstrate a good level of patient experience. In terms of QOF, they are above the the CCG average achievement for QOF, and there's nothing to suggest that the branch closure would impact on that in any way. The last, sorry.
Could I just ask you to explain for the members of the public what QOF is?
Yeah, it's quality outcomes framework. Sorry, and this is it's not mandatory. This is something that practices choose to either opt into or opt out of. All the practices in Tees Valley have opted in, and there are a number of areas and targets that they need to that they are required to meet, and if they achieve those targets, then they are paid on a sliding scale for that achievement. If there are any questions at the end in relation to QOF specifically, that's fine, but I could go on forever in terms of.
That was great. That was smashing. Thanks.
Okay. In terms of the last CQC inspection, that's the Care Quality Commission, who are the regulators. That was undertaken in 2016 when they achieved an overall rating of good. But it should be noted actually that the Saltburn branch, because it's not a registered premises, because it's a branch surgery of the main site, that was not inspected at that time. The regulator are not required to inspect branch sites. A desktop review was undertaken in September, and that did not trigger any concerns from CQC that they wanted to undertake any further assessment of the practice. In terms of the engagement process, the practice have undertaken a 6-week period of engagement between the 5th of July and the 15th of August to gain a better understanding of the impact of the temporary closure on patients, and also the potential impact of a permanent closure. So 6,187 patients over the age of 16 years were invited to participate, and also stakeholders. Of the 6,187 patients, there were 645 responses, and 76% of those were from patients whose preferred site was the branch site in Saltburn. And of those 645, 37% were aware of the temporary branch closure. In terms of the issues that were raised throughout the engagement process, that there was some concern from patients around the increased travelling times, that they would need a car to be able to get to the Saltburn practice by around between 15 and 30 minutes additional travelling time. Most patients said that they would prefer the practice to be in walking distance, although there were the majority said that having a GP practice open between 8 AM and 6 PM was very important to them, and the branch surgery currently is open between was open prior to the temporary closure, was open between 8:30 AM and 1 PM only. Overall, in terms of concern about the closure, 45% of the patients who responded were not at all concerned about the closure and any impact on themselves. 28% were either very concerned or slightly concerned, 11% were slightly concerned, and 15% were neutral. In terms of stakeholder engagement, Cleveland LMC supported the application, and the Adult and Communities Scrutiny and Improvement Committee, the CCG and the practice attended two meetings, one on the 13th of July and one on the 21st of September, and no concerns were raised following those meetings. The NHS England did contact the scrutiny committee, who advised that they were just waiting to that they did have no further comments to make, but obviously were awaiting the outcome of the decision of committee. We also contacted the 4 practices who are located within the 5-mile radius of the branch surgery, and they had no further comments or concerns to raise. In terms of assurance for committee, the application has been received in accordance with the February 2021 Primary Medical Care Policy and Guidance Manual, and should a permanent closure be approved, the NHS England exit planning process will be utilised to ensure an appropriate close down, which would include further engagement with patients and stakeholders. So in terms of options, there are 2 options. One is to decline the application to close the practice, in which case nothing would change. In terms of benefits, there'd be no requirement for patients to travel, greater patient choice, there'd be two sites for patients to choose to utilise. There'd be there would be less pressure on the 4 practices who are closely located. However, there are some risks associated with that as well. The condition of the premises, which are identified within the report itself. There is the situation with the landlord, who we understand is unwilling or unable to develop the premises, and there is no opportunity to develop that further. So in terms of 2 consulting rooms, no central heating, visible damp, etc. And in terms of the workforce and the resilience of the practice, that potentially would be impaired. They have lost staff, they haven't been able to recruit. So that is still a potential risk. In terms of approving the recommendation, all patients would have access, albeit that they would still have the same access, although it would be on one site. There potentially would be increased workforce resilience. It would certainly be delivered from a modern infrastructure, and with increased use of modern technology, the digital technologies to complement patient access. The risks for that, again, would be the travel implications for patients, that patients may decide that they wanted to access one of the practices more local to themselves. So that may result in movement across the practices. Be a financial impact to the CCG for that in year 1, where we would pay for new patient registration fees. In terms of recommendations, it is recommended that the temporary branch closure of the branch site at Saltburn is approved due to the COVID-19 safety environment requirements, which will impact on the delivery of services from that site. It is also recommended that the business case application submitted by the practice for the permanent closure of the site is also approved, as this will allow the practice to consolidate, sorry, tongue-tied, services and the workforce, and that would ensure greater quality of patient care to maintain sustainability and resilience, and provide the practice the best opportunity to further develop and transform in line with the future NHS provision for primary care services. That was a bit of a mouthful. Sorry, that was really long.
No, thank you so much, Sue. Obviously, I've read the report, and it is a really comprehensive report, and decisions like this are always difficult. Yeah. So I think the report is really good. It's really comprehensive. I like the way that you've set out all of the patient engagement, and I mean we can see it line by line in terms of what what patients have said and what some of the challenges are. I'll open it up to members of the committee if they've got any questions for you, if they need any further clarification on any of the issues, or if anybody else wants to add anything. Right, I've got David. I've got your hand up, David.
Yes, thank you, Sue, for the lengthy report and from the summary you've just given. I think it's entirely understandable the reasons for closing this branch surgery, because it seems to me that it's certainly outmoded and no realistic prospects of improving it, and also it's understandable why the practice wants to consolidate staff on one site. My question is regarding possible alternatives in Saltburn. On page 85, section paragraph 2.6, the practice explains how they looked at other options. Two questions on that. Firstly, there is another GP practice in Saltburn, the Huntcliffe surgery. Was the possibility of seeing if there was any capacity to share their premises? And secondly, the second bullet point on page 85, they talked about converting or renting alternative premises. They said they looked at the old sexual health clinic in Saltburn, but did not receive support from the CCG. So just wondered if you could say a little bit more why that wasn't supported and about the capacity at the Huntcliffe surgery.
Sorry, David, I'm just trying to scroll down to page 85. Bear with me.
I think that was the thing that struck me. It said that there was still going to be a surgery in Saltburn, and that the Huntcliffe surgery was 0.01 miles away, so it must be meters away from the existing surgery that there is there, albeit it's a different practice.
Yeah.
So in terms of the Huntcliffe surgery, we're not aware that any discussions had been held, and we know that practices generally are looking for additional space for additional workforce now due to the introduction of the primary care network arrangements and the R scheme, as it's called. So the practice, we'd have to ask the practice, David, if they progressed any discussions, but it's highly unlikely that Saltburn, with their own patients, the Huntcliffe practice, apologies, with their own group of patients and the premises size that they have, based on the premises reimbursement that we receive, that they would have any additional facility or space to house another practice within that. Because looking particularly within the Redcar locality and looking at Huntcliffe itself, they do have quite a large list size. They have a list size of 9,000, and this was as of July this year, actual list size, nearly 9,800, so nearly 10,000 patients in that practice itself. And obviously practices are reimbursed their rental space based on the number of patients they have, and we haven't had any practices advising. We've had practices advising the other way, that they need more premises space for the additional roles that they have, that they've not got spare capacity for space currently. So I suspect that wasn't a solution to try and look at utilisation of that space for the 600 patients. Obviously patients have choice, and that's why the risks were outlined, that patients have this branch practice has been closed during the COVID period, and patients have still been able to access the main site or access remote consultations. And the way that patients are consulted with now has changed as well. So it is expected that if some patients will choose to remain in that practice, still registered with those GPs, whilst they can access the main site and remote consultation. In relation to the sexual health clinic, that was a discussion pre to NHS Tees Valley CCG's times in terms of that approach, and I understand that it wasn't available, the space wasn't available at the time for the practice to be able to progress with the sexual health building as a permanent location for delivery of services.
It's just written that it wasn't supported by the CCG, so I just wondered the reason. But that was due to lack of availability then, was it?
Is my understanding, David.
Yes, thank you.
Yeah, that was pre-NHSP's time.
Thank you.
Okay, has anybody else got any questions or observations for for Sue?
Janet.
It was just, sorry, Carol, it was just to add that Healthcare are a practice that's involved with training of medical students and vocational trainees, and that does mean that they are less likely to have additional space because of their training requirements space-wise.
Smashing. Thanks for that, Janet. Michelle, did you have a comment on the patient engagement bit of it? I think Michelle popped a comment in the chat, didn't she?
Apologies, can you hear me? It's just I'm having problems at the moment.
Yes, we can hear you loud and clear.
Yeah, no, I was really pleased with the report and just the evidence of patient engagement. That's what we like to see, and just ensuring that those voices are there. So yeah, it was really good. Thank you.
Smashing. David, is that an old hand? Yeah. Okay, lovely. Right. Well, I think we've listened to everything that's been said, so I'm going to move to the recommendation. The recommendations, we're being asked to note the content of the report and approve the following recommendations. So a continued temporary closure of the branch site due to the continued COVID-19 safe environment requirements impacting on the delivery of services from this site. So can we approve that? Yeah, everybody's saying yes. Anybody against? No. Okay, lovely. And then the second approval is to approve the business case application submitted by the practice seeking a permanent closure of the branch site at Saltburn to allow the practice to consolidate services and workforce to ensure greater quality of patient care, maintain sustainability and resilience, and provide the practice with the best opportunity to further develop and transform in line with the future NHS vision for primary care services. So are people happy to approve that recommendation? Yeah.
Yes.
Lovely. Thumbs up. Anybody against? No. Okay, that's smashing. Okay, thank you very much for that, folks. We'll press on next then to the next item, which is on page 105.
Caroline,
yeah?
Sorry to interrupt. Lisa has she's put her real hand up. I don't think she's able to put her virtual hand. Oh, she's found her virtual hand now. Her hand's up. Sorry.
Sorry, Lisa, do you want to say something? Oh, we can't hear you.
She just needs to find the mute button now.
Right, okay, sorry about that. I don't know what's going on with my computer today. Yeah, it was just to ask, obviously, I just wondered if you could, I know some initial information's been sent across to Health Watch on Karen Cleveland, but I just wondered if just some general information could be sent across to us as to sort of those alternatives and what a patient might do if they come to us just asking just for some advice or where they can go. It would just be really handy to have some sort of either like crib sheet or sort of options, just so all the team are all sort of saying the same thing, we're giving the same messages across, just in case anybody does contact us in relation to this. That would just be really useful, if that's okay.
So Lisa, just picking up on what we will do is, as was set out in the paper, we'll be engaging NHS England and the practice in relation to the closure of the branch. And I must stress, this is a branch closure, not a practice closure. So it's the patients that prefer that site is about 600 patients in comparison to the rest that access the main site. But absolutely, we'll work with NHS England, the practice, to come up with an overview around how they will exit, because bearing in mind that site is temporarily closed and we've just agreed to keep that temporarily closed, there will be a process that practice will have to undertake to close down the branch and also engage and communicate with patients and stakeholders, including yourself as a stakeholder, to come back and make sure that you're clear of what the arrangements are and what date that site will actually, and again I'll reiterate, it's a branch site, that site will ultimately close, and we have also given that commitment to the scrutiny committee in Redcar as well, that we'll further engage to ensure that they're aware of the process that will be undertaken. So after today, we'll work with the practice in Culvey as the NHS England lead will guide us in terms of making sure that due process is adhered to for reassurance for all of the committee members.
That's brilliant. Thanks, Karen. Sorry, I lost me sound again at the beginning of that, but I think I've picked up what you're saying. But yeah, anything that goes out, just copy us in, and then we know that we're responding in the best way and the right way as well. That would be brilliant. Thank you.
Smashing. No bother at all, Lisa. Well, okay, with that then, folks, I'm gonna move us on to item 45, which is on page 105, and that's over to you, Sue. I hope you've still got your voice, and that's the Mackenzie Group practice contract, and this is an update regarding the application to close the Hartfields medical practice. So you were able to take us through that, Sue?
Yes, I will. Yeah. So Mackenzie Group attended committee in February this year, and they advised of their intention to submit an application for the permanent closure of the surgery at Hartfields. Hartfields had been closed temporarily since March 2020, as they had been unable to provide a COVID-safe environment for patients and staff. At the meeting in February, committee advised that the practice would need to undertake patient and stakeholder engagement first to determine the impact of the temporary closure, both on patients, but also the potential impact of permanent closure prior, and then they would need to submit a business case on the back of the findings of that. Engagement was undertaken between the 19th of July and the 29th of August, and it included a meeting with the Hartlepool Audit and Governance Committee on the 27th of August, which the CCG and the practice attended, and again on the 22nd of September, when the practice presented the results of the engagement exercise. However, following the analysis of the patient and stakeholder feedback, the practice has decided that it wants to undertake a further period of engagement. And committee may remember that when they came in February, it was outlined and proposed that the business case would be submitted to this meeting. However, that business case for the permanent closure clearly is not in a position to be submitted at the moment, and it won't be until that engagement period and evaluation process has been concluded. So that is likely to be next year. It won't be done by December either. As a CCG, we're working with NHS England and the next comms team to agree next steps and to ensure that due process is followed. In terms of the temporary branch closure, the practice has therefore requested an extension to the temporary closure of Hartfields on the basis that they are unable to provide a COVID-safe environment and for practice workforce and resilience. To support the decision-making process, an independent review, it is referred to in the paper, but it hadn't been undertaken at the time that the paper was submitted. But I will be able to send a copy of this over to the corporate team, and it can be circulated just for assurance, really. It can be circulated with the minutes of the meeting. But an independent review of the premises was undertaken earlier this month. And in summary, it was an infection prevention and control nurse who undertook that assessment for us. She did make some specific recommendations in relation to things like the maximum number of people who should be in offices or in the waiting rooms to ensure the 2-metre social distancing measures were maintained. Recommendations in terms of hand sanitisers being put in places where they weren't there already. The use of surgical masks when patients attend rather than cloth or face coverings. And with the exception of the treatment room and the waiting room, there were no issues reported in terms of natural light or ventilation that would prevent the practice, the branch surgery reopening. In terms of the treatment room, it has no natural light and no natural ventilation, although there is an air extraction system in the ceiling, and we are asking for that to be checked to understand the number of air changes per hour to reduce the airborne particles. The recommendation is that there should be 6 per hour, and that would reduce the airborne particles to less than 1%. We are trying to ascertain whether that is the case or not. And the recommendation is that if it isn't 6 per hour, then the room should be used less often to allow fallow time between patients, although there isn't a recommendation at the moment in terms of what the reduction in that should be to determine what the impact would be on the practice, delivering services from there. The other recommendation in terms of the waiting room is around ventilate to ensure air circulation, that the door remains open, and that we're just checking both on the fire regulations and confidentiality aspect of that happening. The other thing to note is that the infection prevention and control guidelines were changed on the 14th of October, which is after this was undertaken, which reduced the social distancing from 2 meters to 1 meter. Although I don't think that will have any impact in terms of it may mean that more patients can be in the waiting room at any one time, but it certainly won't impact on anything else. Bearing in mind the 2 issues that have been raised that we've not been able to get a response to in time for this meeting, and although there isn't a recommendation included in the report, it is recommended that to ensure the safety of patients and staff, that the temporary closure of Hartfields remains in place pending the outcome of those 2 areas in terms of the waiting room and the treatment room. So it remains not, the request was that it remain closed till the end of March, but if it can be remain closed until the outcome of that, and we'll bring a recommendation back to the December meeting.
Smashing. Thanks for that, Sue. Has anybody got any questions or anything further that would like to add in relation to that report? Let's have a look. I've got David Gallagher.
Yeah, thanks, Caroline. Again, thanks. That's really helpful to hear that in the way you've laid it out, so really clear for us. I think we just need to bear in mind the distinction between temporary closure, which is what they're asking for, and I think it's a good thing, to be fair, that they're asking for longer to consider the branch, because it means they can have more patient engagement involvement in the process. I'm sure will help with that. And I would be really keen that we actually stipulate an end point to the temporary closure, just so we're clear about what we're talking about, and it could be pending the information. So that's really helpful. Thanks.
Okay, that's smashing. Thanks for that, David. Janice?
It was just 2 things, and I think I agree in terms of the report and all the work that's gone into that, and the fact that Mackenzie Group are looking at it and engaging further is absolutely the right thing to do. I think it was on the temporary closure side of things, and there was just 2 points to note. Is at the start of the report that you gave, as in the oral report today, you mentioned that there was 2 elements to it. So one was regarding COVID safety, and the other was regarding workforce and capacity. And it's just to make sure we don't lose sight of the second and what's safe in looking at the practicalities of the first. So it's just to make sure that we're considering in the round. And then the other side was just a note of caution on the 2 metre rule being removed in general practice. That does have a number of caveats with it. That does actually lead to having separate channels for people where they can't demonstrate double vaccinations, they can't demonstrate that they don't have COVID or they're not COVID symptomatic. So on that basis, even though those rules have been relieved in terms of the 2 metre distancing, there's still quite a lot in terms of the way that you run the practice and the spacing, so as to avoid not having a double system and respecting people's choice as well in terms of care, vaccinations, etc. So it's just to highlight that as well, rather than us just thinking, well, that's been removed, so it's all great back in the waiting rooms, because that's not the case.
Brilliant. Thanks for that, Janice. Has anybody else got anything that they'd like to add or to ask? No, I can't see any other hands up. I'm pleased to see the extension, because I presume we'll get a business case as comprehensive as the one that we've seen previously to enable us to make an informed decision. And obviously the comprehensive patient engagement and stakeholder engagement would be really helpful as well. So that would be good to see that. Karen?
Yeah, and I think that's just reiterating, Caroline, what Dave had raised in terms of we've been very clear, both with the practice and with our stakeholders that we've engaged with, that the virtue of agreeing to a temporary closure to the branch because of the issues around the branch currently is a temporary closure, that there has been no predetermined decisions in relation to the permanent closure and the request of the practice until we receive that information, and that we do our own needs assessment on the back of that. And I think it's really important that although we've sought guidance in relation to the IPC, and that's why we wanted to reassure the committee that the request around IPC in the closure, because this closure was originally due to COVID infection rates and protection of staff and patients, that we sought external guidance in relation to use of that building going forward. And that's why once we've clarified those 2 areas, we can obviously look at that again through the lens of COVID, but we would also look at it through the lens of workforce within that practice. But I think it's just worth reiterating that we have not, through this committee, by virtue that a decision may be made around continuing that temporary closure, that predetermines any permanent closure arrangements as we move forward.
Absolutely. Yeah, absolutely. Thanks for that, Karen. It was good to see the independent take as well in terms of the safety of the premises moving forward. Yeah. I found that really helpful. So thanks for doing that. Right, okay, folks, I'm going to move us to the recommendations then. So what we're being asked to do is to note the update provided with regards to the engagement process being undertaken by the practice and the subsequent delay in the application expected to be submitted to the Primary Care Committee. So we recognise that is going to be delayed. So we're okay to note that? Yeah.
Yes.
Yeah, lovely. Okay. And then to consider the request from the Mackenzie Group to extend the temporary closure of the Hartfield site due to the COVID risk assessment concerns associated with the updated infection prevention control guidance. So are we happy to extend the temporary closure, but make it very clear that it is a temporary closure pending this full business case that will be presented at a later date? Okay. Yes. Yeah. Everybody okay with that?
Can I just check,
yes.
Caroline, the outcome of the 2 issues that have been raised in relation to the treatment room and waiting room are likely that will come back in December. I'm sure that we will get an answer to those before the business case, which will not come before next year. So do you want the temporary closure to come back to the December meeting for consideration? Yeah.
I would have said yes.
Yeah, okay.
Yeah, everybody else happy with that?
Yeah.
Yeah.
I think we need to deal with them completely separately. As
yeah.
Caroline, so we need to do that, yeah.
Yeah.
Yeah, okay, that's smashing. Right, thanks very much,
Thank
Sue.
you.
Thank you for that. You're on a roll today.
I need to go and get a drink.
So we're on to we are running a bit behind, but we're on to agenda item 46, and it's on page 110, and this is the prospect surgery and the CQC inspection report, and Culvey's going to take us through that, so you can go and nick off and have that drink, Sue. Okay. And Janet's going to step out for a moment to sort out this call, but we're okay because we're still quorate. So over to you, Culvey.
Thank you. So following a specific incident that was reported to CQC, on the 23rd of June, they carried out a responsive focused inspection of prospect surgery to assess the safety of non-therapeutic circumcision procedures and identified some serious concerns in relation to the safe care and treatment of patients undergoing this procedure, risk assessment, record keeping, governance arrangements. This resulted in the CQC imposing urgent conditions which stipulated that the provider must not carry out this activity without the prior permission of CQC. This procedure is not delivered under the primary care contract, but is the practice of CQC registration. On the 9th of July, CQC undertook an announced focused inspection, including a site visit, which they published the report on the 3rd of September. They rated the practice as inadequate overall. This inspection took place following the concerns identified in the June inspection. A review of the draft report was carried out by the NHS England and Improvement Assistant Medical Director and Senior Clinical Manager of the Nursing and Quality team, who provided a risk rating of 12 and 16 respectively. The main areas of the breach are failure to establish and maintain a patient participation group, failure to ensure appropriate arrangements for infection control and decontamination, failure to meet the national recommendations for cervical screening and provide appropriate follow-up system, failure to ensure clinical health care professionals are registered, failure to ensure any healthcare professions providing services have access to and the opportunity to undertake training with a view to maintaining their competencies, failure to have effective systems of clinical governance, and failure to comply with all relevant legislation and regard for relevant guidance. Further details for each of these areas are detailed in the report. CQC found the practice in breach and have issued 2 enforcement notices and placed the service in special measures. This will be re-inspected within 6 months to review those services placed in these measures. The committee is requested to approve the issuing of a breach notice, at which point a breach notice and the letter will be sent out to the practice as detailed in the report. Thank you.
Smashing, Culvey. Thanks for taking us through that. Has anybody else got anything that they would like to add? Karen, I can see that you've got your hand up.
Yes, thank you, Caroline. So Culvey's taken you through the contractual elements, and as we're a delegated CCG, there's a contractual process that we need to follow. Just to reassure committee and provide some assurance of steps that have been taken with the practice since release of the report and guidance provided by CQC as a regulator, that we have been working with the practice in line with our quality and variation approach that we undertake with all practices, whereby CQC identify any concerns or issues. And we have received a copy of an action plan that the practice will be submitting through to CQC to look at remedy and how they can put remedy actions in place. And that is overseen by our CCG clinical executives within our quality and variation group. Although we are not the regulators, we do provide support to the practice to ensure their improvement and their sustainability. The other area is, although we're working with the practice, we've continued to engage with our stakeholders, and we have attended the Middlesbrough Scrutiny Committee to provide them with an outline in relation to, well, the practice provided them with an outline in relation to the actions that they were undertaking, and obviously to express their disappointment in the findings and to provide their commitment that they will endeavour to ensure remedial actions are in place to improve services within the practice. So I think it's helpful, although we're following a contractual route, because that's what's required under our delegated arrangements, we are also working working with the practice to make sure that they are supported, that they're sustainable. It's really important at this time that we sustain practices in our area and we work with them to improve, and that we keep our stakeholders engaged. So it was just to provide committee with some context and reassurance of the actions that will be undertaken. Obviously, following today, we will be providing updates to the committee as we move forward, as we work with the practice and the regulator.
Brilliant, thanks for that, Karen. That is really helpful, because obviously as you're reading through the report, it doesn't make great reading as you're going through it. David, have you got any questions that you'd like to ask?
Yeah, yes, please. As the original concern related to the surgical procedure, does this practice do other local anaesthetic surgery? And if so, are there any special precautions which are being taken in view of this report?
Not that we're aware of, David. They don't undertake any other procedures, and as you quite rightly say, the procedures that are undertaken aren't under the General Medical Services contract. It's a private service that's delivered, and although they identified concerns through that service, it did prompt the regulator to undertake a visit for the core elements of service. But we're not aware that they provide any other services.
Thank you.
Any other questions or comments for Colby? No? Okay, well, I'm going to move us to the recommendations then. So the recommendations are that we consider the report, which we've done, approve the issue of a breach notice in relation to the breach of regulations 12 and 17 of the Health and Social Care Act, and the regulations 2014 as identified by the CQC during the inspection. So are people happy to approve those recommendations?
Yes.
Yep, okay. Yep, lots of nods there. Yep, that's smashing. Okay, so we'll move on now to the next item, which is item 47, and we're up to page 161 now, and that's the COVID-19 response. And Karen's going to take us through this.
You're going to hear from me now. So just in terms of the paper, obviously committee have received updates regularly through public committee in relation to the responses to COVID that we've undertaken as a CCG. I won't go through the paper in detail because I'll assume that our members have read the detail and have identified the changes, but I'll point out the key highlights. So you'll identify as set out in the table in relation to branch closures. I won't go through Mackenzie and Zetland because I'm sure you're subsumed in that now. But certainly from a Park and Thorntree, Linthorpe and Riverside perspective, you'll be aware that previously committee did grant agreement for those branch sites to close whilst they amalgamated the COVID vaccination programme onto those sites. All three of those sites have now opened, with Park and Thorntree partially reopening. So it was to provide the committee with an update in relation to that. In terms of the other arrangements in relation to the committee's previous decisions, we are asking committee at this point to ratify a decision that was taken through our executive committee, and that was taken through in light of timescales and also to ensure that we were continued to be responsive in relation to primary care and the response to COVID. So committee will be aware that previously we did agree to flex extended hours, which is a directed enhanced service that's provided by practices and as groupings within PCNs. And we did offer PCNs the flexibility whilst they were still delivering the COVID vaccination programme that they could flex those hours to ensure that capacity could be delivered to the programme. We did request that executive agreed for us to continue to put those arrangements in place for extended hours, particularly for those practices that were delivering phase 3 of the programme. Also, our local incentive scheme, our local improvement scheme that we have in place with practices, you'll be aware that during the number of phases of the COVID programme, we stood down the local improvement scheme with the exception of the clinical areas. What we suggested to our executive is that we continued for quarter 3 and quarter 4 as we're heading into the winter period, that we would continue to stand down the elements that were non-clinical within that local improvement scheme, and that we would offer the praxis the ability, therefore, still to stand up the time in elements, so to offer praxis time in to discuss and arrange through their own practices and their groupings as to how they're going to manage winter. And also the area that we asked them to stand back up was the engagement in next year's in the discussions for next year's local improvement scheme, so that we did have that commitment from practices. We also, as you'll be aware, we put in place over the COVID period hot clinics. So those were clinics available in each locality to see those patients who were potentially COVID positive or were diagnosed as COVID positive and still needed to access GP services. So we changed our improved access services to enable patients who were COVID positive to be seen in identified locations to free up capacity within general practice. And we suggested to committee, because of the rise in rates in relation to COVID at that time, and as the COVID continues, it hasn't disappeared, it's still here, and winter's coming, that we would make sure that there was still capacity to support general practice and all practices. And we suggested that the hot clinic capacity continued to be stood up through the winter period until the end of Q4. So those were the arrangements that we had in place previously. The only exception to that is for anyone that was not participating in phase 3 of the COVID programme, because obviously the additional capacity predominantly needed to be with those that were continuing to deliver COVID vaccinations, which are really important, including the booster programme that's now in place. And that the only primary care network in our area that isn't participating is the East Cleveland primary care network. So they are expected to stand those services back up to what was local and national requirements. However, Janet is working very closely with the practices and with our community service provider and our community pharmacies to ensure that the patients within that area are still covered for the programme. Now, the other area in the report is around vaccinations, and I'm sure because we're starting October, but in September, nationally it was announced that phase 3 of the COVID vaccination programme would be rolled out and to be undertaken, and that's the booster programme. But that booster programme does include an evergreen offer, and that means anyone who's never had the COVID vaccination booster or any new announcements from government in terms of any new phases of the programme, that the practices would still be expected to continue to deliver that. Just for clarity, the COVID booster programme, anybody that's had 2 vaccines, 180 days or at the earliest 6 months after their initial vaccine, will receive an invite from their GP practice or their primary care network to attend a site or through the national booking system to have that booster vaccine. And since then, the clinically extremely vulnerable group for 12 to 15-year-olds, which also practices are expected to undertake, were announced during that period in September as well. So a large task as we move forward into the winter period in relation to continuing to ensure that our patients and our population have the COVID booster programme, but also they continue to have an offer if they've not accepted it in the first phase of the COVID vaccination, which is entirely important as we head into a winter period. So what we're asking of committee today is to ratify those decisions that were taken through our executive committee, but also importantly to ensure that you were cited on the arrangements that were put in place to ensure our continuation and sustainability of primary care. Thank you, Caroline.
Brilliant. Thanks for taking us through that, Karen. I did find that report really helpful, keeping us up to date with what's going on. Has anybody got any questions or any observations for Karen in relation to this particular report? No, I think it's pretty straightforward. I'm not going to read through all the recommendations because I know people will have read the papers. So can I just propose that we approve the recommendations set out on page 167 as they're listed? People okay to do that? Yeah.
Yes.
Yeah. Okay, that's smashing. Great. Okay, well, if we can move on then to item 48, and these items are now for discussion rather than decision. And Lynn is going to take us through the primary care budgets as at month 5 and the LMC GP investment templates. So over to you, Lynn.
Great, thanks, Caroline. Yeah, so if you can just point to page 170 of your pack, which has got the latest, well, the position of the financial position as at month 5, which is the end of August, which is demonstrating that we're, to the end of August, we're over plan by £827,000 and predicted to the end of H1, which is the first half of the financial year, and 987,000, which has been consistent, I think, throughout the whole 6-month period that we've been in under this financial regime. Just a little bit of a heads up for month 6, as in the end of H1, the position hasn't changed materially at all, so we are going to land roughly around just under £1 million over plan for the first half of the financial year. Again, a little heads up, we've just recently received our H2 financial envelope, which is for the second half of the financial year, and there's no change to that envelope for the second half. It's exactly the same as the first half of the financial year. We've just gone through quite a lot of papers on the agenda there, which potentially have some financial implications, as in, you know, branch closures, reprocurement of practices and what have you. So there is a potential for the second half of the financial year for some other pressures to emerge through that process. But again, we're hopeful that we'll be able to manage within the existing envelope for H2 as well, and get to the end of the financial year. In addition to this month's pack, we've been asked to provide you with for information, really. So a request that's now part of the GP contract agreement for 2021 is to do a CCG report on the investment in primary care. What you have in your pack there is 3 individual reports, because the period of 1920, we were 3 separate CCGs. So each of the information that you have there is for each of the 3 individual CCGs. And it's just a breakdown of what the primary medical care allocations have been used from. Have been spent on during that financial year, and it mentions there it's to aid positive discussions between ourselves and the LMCs around investment in GP services. We have got an obligation to report these now. It's brand new, and for 2021, which is our new merged CCG, our next iteration of this is due in December, which we'll also bring to the committee for information. And really, that's all I want to say on that, if anybody has any questions.
No, that's smashing, Lynn. Thanks very much for taking us through that. Has anybody got any questions or any observations for Lynn? No, everybody happy with that? I think we get plenty of reports, I think, on the financial stuff. So I think people are pretty familiar with that now. So everybody happy with that? Okay, yeah, well, we're just simply asked to consider that report. So if everybody's happy that they've had the opportunity to ask any questions of Lynn. Okay, yep, that's smashing. Thanks very much, Lynn. I'll move on now then to item 49. And Sue, if she's managed to have a drink, is going to take us through the Ravenscar update.
Yeah, thank you, Caroline. I think this one will be really quick. Because there is some information in there that I know committee are already aware of in terms of the background to the Ravenscar procurement. So I'm not going to go over all of that. So as you know, the contract holder resigned the contract in June, which expired on the 30th of September. Committee approved an emergency procurement for a 12-month period to enable the CCG to undertake an assessment of requirements going forward and undertake market testing to determine whether or not to progress to full procurement. Following the emergency procurement and evaluation exercise, Elm Alliance was awarded the contract from the 1st of October 2021 to the 30th of September 2022. The mobilisation of the service was successfully concluded and the practice is fully operational. For information, the paper sets out a draft timetable for a full procurement, and but that would be on the basis that any recommendations will come back to Primary Care Committee, both in terms of an assessment and evaluation of of a needs assessment for the practice, and also the outcome of market engagement. Although that timetable is there, we will be bringing something back to committee for approval prior to going out to full procurement. That's it, unless there's any questions.
Brilliant, that's smashing, Sue. No, it's pleasing to see how this contract's rolling out. Lisa, you've got your hand up. Have you got a question yet?
Hi, yeah, no, it was just also to add to that. I don't know if you're aware, but we have worked quite closely with ELM in terms of patient engagement, because we were getting a lot of queries through our information and signposting, and we have worked quite closely with them on a number of other previous things. So they came to us to ask us what information they should have in their sort of frequently asked questions sheet that they've sent. We took all of the questions that have been asked from our information and signposting and posed them back as questions. There was also one lady in particular that was quite disgruntled about the experience that she's had. So we've actually put her in direct contact with ELM Alliance, and she's also sort of informing sort of what information patients etc might hear. So it was just to let you know that from a patient perspective that we have been quite active with this surgery.
Okay. Yeah, we do have weekly meetings with ELM. And yeah, I mean, they've certainly advised us that they have been in contact with yourselves. I think, you know, as you would expect, there were a few teething problems. They took over on a Thursday, so you know, a couple of teething problems that would be expected. But it is good that from a disgruntled patient that she's now supporting them to put a positive spin on things, so that is a really positive outcome. So thanks for that.
That's okay, just thought I'd keep you in the loop.
Thank you.
Brilliant, thanks for sharing that, Lisa. David, got your hand up?
Yes, just minor question. There's the timetable of the procurement. The CCGs will no longer be in existence. I just wondered whether that needed just to be modified a bit. It says CCG will seek to undertake a full APMS procurement.
Yeah.
Whether that looks to what CCG and successor organisations or something like that.
Yeah.
The second query, there's reference to the Journal of the European Union. That's still relevant, is it, with Brexit?
Well, it is at the moment, although we have been advised, I mean, even 6 months ago, we were advised that the rules were going to be relaxed, but at the moment they still stand. So obviously, if we are informed of anything officially, then that may impact on that timetable. But that's at this point in time.
Thank you.
Smashing. I think there's going to be quite a bit of that now, David, isn't there, in terms of this period of transition that we're in. Okay.
We remain hopeful.
Yeah. So we're simply asked to note the contents of that report. So thanks very much for that update, Sue. It's really helpful. I'm going to move us on now to item 50, which is the primary care quality and assurance update. And I presume that's over to you as well, Sue. We're certainly getting our money's worth today, aren't we? Thank you so much. Thank you.
Okay, so again, hopefully this will be fairly quick and straightforward. It is an update paper, and again, it's to provide assurance to committee that we as a CCG continue to follow our robust assurance management programme. Not going to go through it all in detail because it is an update, so I'm sure you've heard most of it before. But obviously, if there are any questions, then just shout up. As previously reported, due to the pandemic, several of the data sources that we would have used previously are still either unavailable or not considered to be reflective of current practice. So things like QOF, for example, because that was paused last year. So therefore, the data that we use, we do continue to work in the context of what is happening at practice level, alongside any soft intelligence, and that enables us to have a more informed discussion at this stage around potential risks, quality of patient safety, and we do that through the quality and variation group, where any appropriate levels of intervention are agreed, and that may range from informal support, it may be quality improvement plans, or it may be moving to a formal contract management sanctions. In terms of CQC, they're continuing to work under transitional monitoring arrangements, as we outlined in the paper. We have got 3 practices, as you are well aware of now, 3 practices who are currently being supported through their CQC ratings. Woodside, who requires improvement, Prospect, who you've just heard of being rated overall as inadequate, and Cotham Surgery, who it says in the paper we're awaiting their rating. That has now been published. It was published on the 14th of October, and they remain in requires improvement. In terms of the things that the quality and variation group have looked at and considered, the CQC quality improvement plans for the practices who for the 3 practices I've just outlined, and also in terms of OPAL reporting. So this is it is increasing the number of practices that are reporting higher levels of OPAL, and in the 3 months from the 1st of June to the 30th of September, there are 337 practices who've reported at OPAL 2, 129 at OPAL 3, and 67 at OPAL 4. Now that is an increase, but both the CCG and the LMC have encouraged practices to start reporting, because from a system perspective, previously, because the OPAL system for primary care was introduced last October, during the pandemic, and so practices previously and historically have not been able to report their the pressures that they've been experiencing. And so from a system perspective, it's always been anecdotal, and it's looked as though actually practices are not under pressure. So we have encouraged, and so have the LMC, have encouraged practices to start reporting. So that is a good thing that they are doing that. The OPAL framework does set out, oh sorry, Karen's just put a,
keep going, Sue.
Sorry, just keep trying to read things as they pop up on the screen. The OPAL framework does set out a number of measures that practices should consider taking when reporting pressures. And what we are doing is, where practices reporting at OPAL 4, we do have conversations with the practices individually to discuss what measures they have considered, what measures they might not have considered, and what options, you know, there are open to them, and that would be agreed on an individual practice basis. In terms of the GP survey, that's an Ipsos Mori survey. It started in 2007, and it has been updated this year to reflect the pandemic. It is sent to a small percentage of the total population. So for T's, it was sent to 28,203 patients, which represents 4% of the Tees Valley population. So it's got, the results of that have to be taken in that context, and that is something that we never take the GP patient survey results and look at them in isolation. We would always review that in terms of other information that we have available as well. So in summary, with the exception of the practices who have had CQC enforcement action taken against them. There are no other practices who require any form of formal contract management under stage 3 of the SOP, and there are no issues that we want to escalate to committee at this time. Next update will be the February 2022 meeting.
Brilliant. Thanks for that, Sue. I really like that report. Sorry if you can hear the dog in the background. She's had a hip operation, so she's caged up. She's not very happy at the moment. Nowhere else I can put her. So I really enjoyed that report in terms of the survey that was carried out. I did think that was really helpful, and I thought the numbers were still quite significant, even though I get what you're saying. That was still a good return, I thought, in terms of the number of people that have filled that in, and I thought it was really helpful to see sort of like the surgeries side by side, and the 83% at the front end of it in terms of overall. How would you describe your experience of your GP practice? 83% good, which is in line with the national again. I thought, because I know that surgeries are under increasing pressure at the moment, and I thought that was really helpful. There's a few hands going up there. Michelle, are you still here, Michelle? No, it's okay. Go on, over to you, Dave.
Thanks. I was going to say she's here initially, but that's a terrible joke, so I'm not. I think this report is really good. It kind of provides the context for the committee within which we work, so really good, really useful to see. Just to comment on the OPAL bit and just reflecting on when OPAL was used for foundation trusts, we found initially that trusts underreported, then they started to over-report, and it kind of gravitates. I think we're in the process of just getting that balance right, because there's always a perception, one, it's used for performance management, which it's not. It's about trying to help. And two, that it can be used to actually gain extra resource. It can be, but it's really there just to gauge the degree of pressure, and so the system can work together to make sure that we're all doing the right thing. So it's good to see the progress being made, but it does take a while just to gravitate to the right level.
Yeah, and I think the other thing is, for 80 practices, it's subjective, isn't it, as well? And so, I think, there are a few things, but it is good that they are recognising the benefit of reporting.
I did wonder if it would be helpful with the OPAL stuff, which was the point that Karen made in the chat about the number of practices. So if there's 300 and whatever incidents, if we're able to say that does come from so many practices.
Yeah, and I think the other thing is that what we are experiencing is that sometimes a practice will report at OPAL level 2 at the beginning of the day, and during the day they might report at 3 or 4. So it might be that it's not always different practices. It might be the same practice who are reporting throughout the day as they feel under more pressure.
Karen?
I think Dave just wanted to come in there.
I was just going to come in. It's by definition, and by the way we do it, there'll always be a degree of subjectivity to this, but actually what we're trying to do is get as objective as possible, because it should be measuring actually where they are and the steps that they're taking, because they're at different levels. And again, as it matures, that will become easier for them, to be fair.
And Karen, did you want to add a comment?
I think it was more to pick up on obviously in the context of what's just been reported, and David's query in relation to access, because it all links, doesn't it, in terms of the patient access survey and the query that David raised under any other business for our practices open. And I thought I could pick up that bit, and then I'll pick up the new improving access requirements that have come out that might be helpful from a committee's perspective. So I just think from a committee's perspective, and to reassure committee and provide assurance, not just to reassure, but to provide assurance, Obviously, you'll be aware that the pandemic has led to absolutely unprecedented demand for GP services. The social distancing measures that we've talked about earlier and other infection prevention control measures at the outset of the pandemic did have an impact on the capacity of many parts of the system, including GP services, and to enable them to consult with patients face to face. Obviously, practices during this period, they did move to adapt into new ways of consulting with patients, including video consultation, e-consultation, and enhanced telephony consultations. And that was done under instruction, under a standard operating process, but also to ensure that both patients and staff were protected in line with the national guidance, and that practices were advised and are continued to advise that where clinically necessary, that's where you should bring patients into the surgery following triage. And that again is to protect both patients and staff. And for assurance for our committee, other than the branch closures that you've already seen throughout the COVID pandemic period, because we've kept you cited on those, practices in our area do remain open. However, they do still have infection prevention control measures as are being directed by Public Health England, and are still continuing to utilise those in determining when they should be seeing patients face to face. But despite all of those challenges throughout this period, our practices and GPs have been absolutely committed to maintaining primary care services. They've rapidly adapted to meeting the demands and delivering the new requirements, and delivering these not only during a pandemic, but during the delivery of a COVID vaccination programme, and now even more recently the flu vaccination programme. So in terms of the practices and to meet the increased demand that they currently still are seeing, COVID, as I said earlier, hasn't disappeared. We've got winter ahead of us and it feels like we're already there. And to deal with that and the backlog in general practice, they will continue to work differently for some time, including the use of different ways of consultation with patients. But that should be also in line with clinical best practice, and where patients need to be seen, they should be and will be seen. Although there are many frustrations in relation to the new way of working, there are also some real benefits to patients in terms of new ways of consultation. And we are working, obviously, and have sent out recently patient leaflets and communication in terms of how patients can access GP services. But I thought it was helpful to assure committee in the context of, during all of that and during the delivery of a COVID vaccination programme, our practices have remained open and continue to do so. So in line with that, there has been guidance that has been received from NHS England, and you may have seen it on the news and in local reporting. And that guidance is our plan for improving access and support in general practice over the winter period. So the guidance was received on the 14th of October, and there is an expectation from an integrated care system, but working together at locality levels and importantly place, that we develop plans across our area to address the priority of winter for primary care. Now, the guidance that was received, it was split into 3 different areas, and it was increasing and optimising capacity, addressing variation and encouraging good practice, and zero tolerance of abuse and public communications. And that's really important because our practices have really struggled during this period, that all of those areas are addressed in different ways. And importantly, the really good news story is that nationally there is winter access funding available for primary care, and that isn't something that's been made available nationally before, so we really need to look at the benefits of that. There is 2 main uses of that as we move forward, and it's to drive improved access to urgent same-day primary care services, and also to increase resilience of the NHS urgent care system during the winter period. We know it becomes very busy during winter, and importantly, we need to make sure that when patients need to be seen, that they are seen. So there is expected to be a system level plan and a plan submitted up to our regional teams by the end of this month. And we will be working with practices and also across the system to ensure that we're able to look at how we better support patients during the winter period, and also support primary care to continue the good work that they've done throughout this period. And as we head into the winter, you'll see, obviously, with the timescales of the documentation only being received just over a week ago, there wasn't time to prepare a paper. But what we will do is we will send out the link to the documentation that's available nationally for that improving access and supporting general practice guidance. But we will bring an update back to the December committee, so that committee have an overview of the plans that have been put in place across primary care to address winter and the priorities that we will need to look at in the coming weeks.
Brilliant. Thanks for that, Karen. That is really helpful. I've got some hands going up there. David Roberts, would you like to ask a question?
Hi, yes. So I'm from County Durham and Darlington Local Medical Community. For those of you who don't know, I assume that Janice, who's on the call, is Janice Foster from Cleveland LMC. Just a bit of context for everybody. So although the proposal was called supporting practice and improving access, this was not and much of it impacts on general practice. This was not an initiative that was discussed in any way with the GP leadership at a national level, and the general tone of the document and the way it was launched, and on a background and with a context of what many GP colleagues feel is a concerted media campaign denigrating the work that they're doing and their current position. This was not well received by GPs. They've really been incensed by this sort of approach without any real consultation about an area that affects so many of our practices. You've had a discussion about that, I think illustrates to some extent the stress and strains that practices are under. And I know that you're all perfectly well aware that all sectors of the NHS are simply exhausted, I think. And general practices are no exception to that. And this sort of environment of what seems to many of us to be hostility and a lack of constructive dialogue from national leadership, from NHS England and the Department of Health, is really unhelpful and does not engender any kind of goodwill from the profession as a whole, I'm afraid. So anyway, as a result of that, there are lots of national meetings led by essentially the BMA, which is the Doctors' Trade Union, to discuss how best to respond to the imposition of an element of the imposition of a plan which has within it some fairly significant adverse impacts for general practices. I'm not going to detail what the actions that we might take are, but just so you're aware, if you see some noise and some information in the media about the response to this plan from general practice and from general practitioners, you have some understanding of the context of the anger that exists out there in general practice about the sort of general, I think realistically, the general attitude to general practitioners that seems to be coming from the centre at the moment. I'll just close by saying that's quite distinct from the really good and constructive relationships we have with NHS England and local CCGs. I'm quite sure that if you know, an amount of flexibility had been given to local CCGs, we would have worked constructively with our colleagues from CCGs and indeed local NHS England to produce a much better received package of measures than has apparently been foisted upon us. Thank you.
Thanks for that insight, David. That is helpful to hear. And I think obviously chairing these committees over a period of time, I think the people who are sitting around this table are well familiar with some of the challenges that they've been, and are really I think really appreciative and thankful for the services that have been delivered in very stressful and unprecedented circumstances. David, you've got your hand up. Do you want to comment?
Yeah, just a quick comment, and thanks, David, and particularly for the last bit, which I'll comment on. But I think we all recognise that the national document hadn't landed very well. We all recognise that general practice is under pressure, the whole system's under pressure, and I think the key bit's the last bit that you picked up, that from an ICS perspective, and more locally from the CCG and the Tees Valley perspective, we are very keen to continue to work with and support general practice to work with the challenges that are there, and some of it will be short-termism, but there's a longer-term plan that we know we need to get into. But we're very supportive of making the improvements and the progress and supporting general practice, as with the whole system, to make sure we get this right. So yeah, understand the sentiment, but we're glad you made the comments locally, because we're onto this, and the team is working extremely hard to work with practices, as you've alluded to move this forward and get a positive outcome for everybody.
Thanks, David. That's much appreciated.
Yeah, thank you very much. So with that, because I'm conscious of time, so we were asked to consider the report that Sue presented in terms of the quality and assurance update. So happy that we've had a good discussion about that, and everybody's had the opportunity to comment and ask questions. So if I can move on now to items of note or any other business. So we had the one item of any other business that David raised at the beginning of the meeting about the face-to-face stuff. I think probably Karen's covered a lot of that, but is there anything else that you want to ask, or anything else that you want to add, Karen? No, we have, like I said, I think we've had a good debate about that. So the next item is any questions from members of the public. I think we've still got, whether we've actually got any members of the public left on. I know that Anne dropped a note in the chat and said she had to leave. I don't know if Chris wants to ask anything. Is Chris still with us?
Still with you, not on this occasion.
Lovely. Okay, thanks, Chris. I hope you found the meeting helpful. So with that, then, if we can consider the impact on the risk register, and if people are happy, then what we'll do is we'll do as we normally do and present a summary of the content of this meeting to the governing body. Are people happy with that? I've lost everybody's faces. Where's everybody gone? Sorry, folks.
Yes,
yeah, people are happy with that. I've gone on to just one screen now, one photo. Sorry, folks. And then key items or decisions to report. Sorry, I've flipped those over. In terms of the risk register, is there any items that we've discussed there that we feel that we need to update the risk register with? I'm just thinking about the. I was going to say Chloe's. It's not Chloe's. It's the, what was it? The
local levels.
Yes.
So it's all of those items that have been covered today are already on the risk register, Caroline, under GP contracting in our delegated duties.
Okay, that's smashing. I'm happy with that then. So if people are happy, then we'll just move on to the date and time of the next meeting, which is not till December the 21st at 2 o'clock. So if I don't see you before, I'll see you at that. And we're just going, I'm going to allow a 5-minute comfort break, if that's okay, not least for the dog. So if we do a 5-minute comfort break, and if people can join the in committee meeting, if I say at 5 to 5, give people about 8 minutes to nip to the loo. Okay, so I'll see you at 5 to 5 on Teams. Okay, thank you very much, folks. Cheerio.